Good evening. I hope you and your family are keeping safe and healthy during this extraordinary time in all of our lives. My name is Perry Essler, and I'm the Executive Director at Jesse's Journey. I would like to thank all of you for joining us this evening from across Canada and in the US for being part of our first ever virtual research grant announcement. Now, before we get into the event this evening, and to get a sense of where people are joining us from, we have a couple of quick polls. You'll see it come up on your screen. Rochelle, if you would enable the first poll. This will give us a sense of where you're joining us from, whether it's London, where it all began, Ontario, across Canada, somewhere in the United States, or perhaps outside of North America. And as the poll goes on, obviously, high attendance in Ontario and Quebec, but it's nice to see other provinces represented. And of course, some folks joining us from the United States. Second poll for us this evening, what's your connection to Jesse's Journey? Some people were volunteers on that walk in '95 and again in '98. Others are Duchenne families, Duchenne parents or patients. Researchers are involved, healthcare professionals, industry partners. It's nice to have a cross-representation of so many different people with us here this evening. Thank you very much. Well, we have a lot in store for you this evening. In fact, it's a jam-packed agenda. We'll hear from the founder of Jesse's Journey and the impact that people like you have made to the landscape of Duchenne across North America. We'll hear about the Research Advisory Committee at Jesse's Journey and an inspirational reflection from a current research grant participant. Finally, you will be the first to meet this year's grant recipients and hear a little bit about their exciting projects and what it may mean for those living with Duchenne. Now, raise your hand if you knew that 2020 was actually the 25th year of Jesse's Journey. Many of you are joining us with fond memories of participating as a volunteer in '95 or perhaps again in 1998. It was only on May 20th, just last week was the anniversary, that the Davidson family set out on an incredible mission to raise funds and awareness for the most common fatal genetic disease diagnosed in childhood, Duchenne Muscular Dystrophy. John pushed his son, Jesse, 15 at the time, across Ontario in his wheelchair, a trek of 3,339 kilometers. And the journey became a rallying point for people in communities across Ontario and across Canada, creating a legacy that would come to be called Jesse's Journey. Since then, Jesse's Journey has become the largest funder for Duchenne research in Canada, funding more than $11.5 million in projects around the world. Though Duchenne is the most common fatal genetic disorder diagnosed in childhood, it is considered a rare disease affecting 1 in every 7,200 male births. Because rare diseases like Duchenne affect a smaller number of people than those with more common illnesses, it becomes far more challenging to find the investment into scientific understanding and treatment development. This is where you come in, our donors, our supporters. You have made a tremendous difference for Canadian boys and people around the world in Duchenne. Through your support, we have seen major advancements in clinical discoveries, significant improvements in the quality of life for those living with Duchenne, and children with Duchenne are living longer lives. While we celebrate the progress made throughout the past 25 years, and we'll touch on that more tonight, we recognize that we are still in a race against time to find a cure and a fight to ensure Canadian boys and young men have equal access to treatments that are developed in other parts of the world. Later tonight, you'll see a video from our inspirational adult ambassador, Douglas Elton, who shares his message of hope. Hope for a treatment to stop the progression of this disease and create a future without Duchenne. Like Douglas, our vision is a world free from the physical and emotional anguish of Duchenne muscular dystrophy. We know we can get there, and we know that research is the key, but we also know this: if research isn't funded, it doesn't happen. And if we don't advocate for access to treatments once they are discovered, our boys and young men will suffer. I'd now like to introduce the founder of Jesse's Journey, who you saw just a couple of minutes ago, John Davidson. John?
As Jesse's Journey is proud to announce our funding commitments for the upcoming year. Tonight, I want to take just a moment to look back briefly as we mark the 25th anniversary at Jesse's journey. We began our first road adventure because, well, quite frankly, we felt we had to. Crossing Ontario was our way of signaling to the country and eventually to the world that we were taking a new approach to funding research. After Jesse's diagnosis, I asked myself, how does buying another wheelchair help to solve this problem? The answer was, it was not going to solve the problem. That is why we decided to focus on the long and difficult road ahead by focusing strictly on research. We followed our journey across Ontario with a walk across Canada to further entrench our ability to fund research. And in the years that followed, we continued to grow while always funding the most promising research, and now Jesse's journey, as Perry just mentioned, is Canada's leader in funding research in Duchenne Muscular Dystrophy. We have traveled down many roads together, and a lot of those roads, quite frankly, proved to be dead ends. But with grit and perseverance, we stayed the course, and there are a lot of reasons to be hopeful that a treatment and eventually a cure is within our grasp. I can tell you that I wanted this, as you can understand, to happen in Jesse's lifetime, but that was not to be. But today we are continuing our quest to aid the family that makes up our family of families at Jesse's journey. Some of them are at the very beginning of their journey, and I have every expectation that we will be there for them and we will be in time for them. Thank you very much for being with us tonight. Perry?
Thank you, John. Appreciate those words. Thank you for sharing your passion and your inspiration with us this evening. Now I'd like to introduce you to another amazing person in Duchenne muscular dystrophy research and an advocate. Her name is Pat Furlong. To some, her name may be familiar to you, as Pat, like John, is a Duchenne parent. Her sons, Chris and Patrick, were diagnosed with Duchenne muscular dystrophy at about the same time as Jesse. Pat is the president and CEO of Parent Project Muscular Dystrophy in the United States. As Pat says, when she and her family launched PPMD, the Davidsons started Jesse's journey. It was two families seeking answers. They had hoped for answers, and in what they found strength that made commitment to their respective countries to raise money and invest in research while all delivering hope. While their sons may have passed, their hope and strength remain that we will defeat Duchenne. Ladies and gentlemen, please welcome Pat Furlong. Pat?
Thank you so much, Perry, and thank you so much, John, for including me tonight. What an amazing journey we've had together. Perry, or who's doing my slides, can start the first slide and a little bit of the story. These are my two sons. I met John and Shireen and Jesse in Memphis, Tennessee. We were looking for answers. We were hoping for that magic bullet that would take us back to the plans and the dreams that we had long ago. And we used to sing this song, Walking in Memphis, because we thought we did have a prayer in Memphis about the research that was going on. Next slide. What we learned that year and in the years following is that there was a great deal more that was needed before we could really envision treatments and cure. At the time in the 80s and 90s, there were no standards of care. There was no government investment in the United States. There was very little interest in rare diseases, no pharmaceutical companies or biotechs looking for answers or even interested in this rare disease. There was no subspecialty interest such as cardiologist, pulmonologist, and sadly, Jesse, Christopher, and Patrick really weren't in the era where such things were available to improve both the quality and their lifespan. Next slide. Next slide. So when we think about what happens to a parent when they get this diagnosis, right? You think about all of the things that occur. You go to Google these days. John and Shireen and I didn't have Google. You investigate where's the best care, who are the best doctors, who's doing the research, where's the investment, what can we do first? And so after we met down there in Memphis, Tennessee, we both decided to set out on a journey on our own countries to see if we could make a difference. And our very first meeting was in London, Ontario at the Robarts Research Institute. John and Shireen and myself and about 4 parents from the United States got together with leading researchers and asked the question, what can we do to move this field forward? Next slide. So I started in the United States, PPMD, or Parent Project Muscular Dystrophy. Next slide. And the reason that I did that was because I followed some basic principles of mine. I'm in medicine myself with a degree in nursing and having had an experience in medicine in transplantation and renal disease. I felt that parents could do something, maybe something more than anyone else could do because of the urgency. I knew we could raise money. I knew we could support research with rigorous review. I knew we would do whatever it takes. I knew we would leave no stone unturned, and I knew that we could work together as countries, as people, as parents, and I knew we would smile one more time. Next slide. So this is our strategy. We wanted to fund opportunistic research, and that's what we did. But we wanted to engage robust advocacy, and the reason for that is to leverage the money we invested. We wanted to demand education and care. You have to start with optimal care. You have to know what a standard of care looks like. You have to deliver it to every person that's diagnosed, and you needed to engage the community. And I don't just mean parents. I mean the scientific community, the medical community, the regulatory community, the payer community, the research community. Everyone has to be all in on trying to find answers to Duchenne muscular dystrophy. Next slide. And here's the reason we're here, right? Because patients are the center of everything. If you don't have patients, there's no need for the rest of it. There's no need for care. There's no need for research. There's no need for pharmaceutical companies to develop therapies. We are the center of everything. And in fact, everything depends on us because the data collected about the people we love is going to inform what happens next. Next slide. So we are 2 different countries, John on his path and us in the United States on our path. We knew we had different challenges and different opportunities. We knew that fundraising would be hard. John pushed Jesse across Canada, amazing, amazing feat, and raised the level of awareness. And we began advocating in the United States. We hired lobbyists, we had meetings, we went across this country, and we felt that Duchenne needed a voice. And indeed, after 25 years, I think it does. Next slide. Our very first step in the United States was someone on the phone. We started the first Duchenne Muscular Dystrophy Research Center at the University of Pittsburgh because Eric Hoffman was there, credited with discovery of the protein product once the gene was cloned in the lab of Luke Kunkel. We also started screening, which was looking at compounds that exist to see if we could make a difference in what drugs were approved right now. And so Eric led the charge on that. We did a second center at DMDRC at UCLA. Eric's center was focused on gene and cell therapy, and the UCLA DMDRC was focused on inflammation. And those were our first steps. Next step. Next slide, please. The third thing we did was in the United States, timing was right for this. We went to the Washington, D.C. together with Joel Wood and others. We crafted some legislation called the Muscular Dystrophy Care Act. This was an entire community coming together around the Dystrophy Care Act. There were three required activities. One is centers of excellence. The meant to care for these young men right now today and how to look forward. Standards of care were published in Lancet in 2010. They were updated. They included care for
Well, that's too bad that we are missing a little bit of what Pat is saying. Her audio and internet connection not working as well.
I'm back, Gary. I can finish up for you.
There you go.
Next slide, please. So this is our timeline. In 2001, we were introduced in the House and Senate this piece of legislation. It went through and was signed into law in 2001. From then until now, $800 million was invested by the US government, the Department of Defense, National Institutes of Health in this disease. I believe it was the tipping point in the United States for pharmaceutical companies to become involved. We also went to the FDA as parents to impress upon them what it meant to have Duchenne, live with Duchenne, and care for a person with Duchenne. We wrote the first draft guidance for regulatory investment, and the FDA in turn wrote their own guidance using ours. So today we sit with 46 companies looking at Duchenne muscular dystrophy, some in preclinical, some in clinical trials, to include gene therapy, anti-inflammation, anti-fibrosis, mitochondrial biogenesis, and stem cell replacement therapies. So we sit at the forefront of possibility for every young man with Duchenne. Next slide. This is how Duchenne is characterized today. You can see in the center Duchenne, and around the red areas the kinds of targets that we have to treat and cure Duchenne muscular dystrophy. Next slide. And here we stand in a drug development pipeline. You'll see in green the restoring dystrophin. So that is gene therapies, antisense oligonucleotides, and other opportunities to express a dystrophin or a related protein. We look at fibrosis, inflammation, calcium imbalance, improving muscle growth and function. And fundamentally, we need to protect these hearts. The heart is a muscle too, and must be treated at the outset and throughout the lifetime. Because if we, through these amazing possibilities, are able to extend ambulation, we have to ask ourselves, is that heart built to last? So cardiac gene therapy is certainly an option for these boys, hopefully someday soon. Next slide. I think from John and Shireen and Jesse, I learned that if you want to walk fast, you'll walk alone. But if you want to walk far, you'll walk together. And indeed we have. Next slide. And this is what I always think about as the last thought. The world breaks everyone, and afterward, all of us are stronger in the broken places. I've altered Ernest Hemingway's quote, and I have apologized in my head 1,000 times for that. We have seen 25 years of progress. We have an amazing 20-year, 25-year history of working together, complementing each other, and all for the same focus and goal, to treat and cure Duchenne muscular dystrophy. And on the phone today with John and Perry, you'll see Danshen Duong, Jacques Tremblay, all old good friends, and Dr. Cohen, all old good friends who've moved this field and changed our lives for the good and forever. Thank you, Perry, for including me tonight.
Thank you, Pat, for attending, and thank you to you and your team for being partners in this together. I feel so strong in terms of how we do this on a united front and not in a competitive way on the behalf of the Duchenne community. So thank you. You complement us in some of the work that we do here in Canada. So it's a pleasure to know you. Pat, thank you again, Pat. And first, now to another inspiring lady who actually works on our team.
Thank you, my pleasure.
Pat.
Thank you, it's my
Thank you, Pat. Like Pat, as I was saying, Nicola Worsfold is a Duchenne mother as well. She joined us at Jesse's Journey last year as our Director of Research and Advocacy. We're happy to have her as she looks after those two important areas, research and advocacy, something that you just heard from Pat and something that we talk about on a regular basis. Nicola, over to you to begin this year's announcements of the research grants from Jesse's Journey.
Thank you, Perry. And hello, everyone. Thank you for joining us this evening and this afternoon for some of you that are coming from the West Coast. I joined this fantastic team at Jesse's Journey earlier last year, so September of 2019. And it was on the heels of our 2019-2020 granting cycle. And so I've had the pleasure of working with a highly esteemed research funding advisory committee, which we affectionately call the RFAC. And this committee, its sole purpose is to solicit and evaluate the research proposals that determine which projects or combination of projects have the greatest potential to translate into clinical treatment for Duchenne muscular dystrophy. Every fall, the Foundation of Gene and Cell Therapy for Jesse's Journey invites researchers from around the world to submit their Duchenne-related research proposals for funding. The funding committee is made up of clinicians, scientists, and Duchenne family members, thoroughly evaluate all of these applications throughout the fall and winter months. It is then that we put forward our recommendations to the board of directors, who then finally make that final approval. And today I'm proud to share with you that this year, Jesse's Journey received the highest number of research grant applications than any other year since we've begun. Jesse's Journey strongly believe in the partnerships of academics, clinicians to fund promising treatments. Since 1995, we have supported 45 research projects granting more than $11.5 million. And we've attracted applications from leading Duchenne researchers from all over the world, including the United States, the United Kingdom, the Netherlands, and Japan. Currently, we have 8 projects that we fund, and these are in their second and third year of funding, including 2 projects that we co-fund with Muscular Dystrophy Canada. Today, you're going to hear about 5 new projects that we will start funding this year. And as Perry has mentioned earlier, it's only because of you, our donors and our supporters, that we are able to fund this pioneering research led by these Duchenne experts, which have resulted in advancements in Duchenne clinical discoveries. But what means the most is that this work has the potential to translate into better quality of life and longevity for children like my son living with Duchenne. So it's now my absolute pleasure to introduce Dr. Ronald Cohen. He's a current recipient of Jesse's Journey Research Funding Grant. Dr. Cohen, who needs very little introduction, has served as president and CEO of the Hospital of Sick Children in Toronto since May 1st, 2019. He's joining us today to talk about how he and his research team have dedicated a large portion of their time to Duchenne research using the groundbreaking genome editing tool called CRISPR, and his passion to change the lives of individuals living with Duchenne. So without further ado, I pass it over to you, Dr. Cohen.
Good evening, everyone. Can you hear me? Hopefully.
Yep, we hear you fine.
And do I have control over the slides?
Yes, I have passed you the remote control.
Okay, let's try this. So while I'm trying this, let me first start by thanking you for inviting me to speak to you. It's not working, you have to move it.
Okay, no problem, I can do that.
But most importantly, thank you all for all your support of not really just our research, but really of the research for so many of my colleagues, some of whom you see today, because I think it is organizations like yours that really allow us scientists to sometimes just go after a creative idea that may be still a little bit too preliminary for some of the more commonly used funding agencies. And I think the kind of support that you provide allows us to think outside the box and most often come up with ideas and pursue them in a way that like no other organization can usually do. So I'm going to give you a quick overview. Can you see? I can't see my slides.
So Dr. Cohen, this is Rochelle. I have control of your slides, I believe. So I'm on the first slide right now. Can you see it okay?
So let's move on to the next one, please.
Okay.
Terrific. So I want to give you just a quick update on one of the areas of CRISPR-mediated genome editing research that we do in my laboratory. Next slide. Which is really around the concept of interventional genomics that is for the first time within the last almost 8 years now, actually already, is allowing us to develop a concept for how we can repair genetic mutations. Next slide. So the work I'm going to present to you today is specifically on work of how you can utilize this genome editing technology that all of you by now have heard about to remove duplications of the dystrophin gene, and it's work from 2 of my graduate students, Eleanor Mino and Daria Votan. Next slide. So if you think about a duplication. In your picture, you see here an A, and then you see a gray A, the duplicated area. Then the most intuitive initial idea of how you can remove a duplication if you have certain so-called genetic scissors is that you take one scissor outside of the A and then one side at the end of the A, and you make a clip, and then you get the wild type gene. Next slide. Now, if you think about that, you have to use two scissors, which you potentially have to package into a virus, then that already makes it a little bit more complicated. And then each one of these scissors comes with its own potential side effect of what we call off targets, which I'll talk to you at the end of the talk. Now, what we came up with in our laboratory, and in part through your support that has supported part of this work, we came up with the idea that you could actually use one scissor to cut in the healthy initial part of the dystrophin gene as well as in the duplicated gene, because it's duplicated, it's the same sequence. And if you look then at the bottom of the slide, you see that you can get one healthy copy of the gene by just using one scissor. Next slide. So we initially used this in dystrophin negative cell of this young patient from London, UK, not London, Ontario. And you can see here in the middle are his cells that do not express dystrophin. Hit the button, please. Oh, the animations are gone. Are you in presentation mode?
I am in presentation mode. I'm so sorry. I don't.
Okay, so now you have to, the thing is you have to believe me now, because what the next slide is about to show is that after we gave the scissor, the CRISPR scissor to the cells, the wild type dystrophin was expressed, which is important. It's the full length dystrophin expression, different than what you see in either microdystrophin gene therapy, where you have a small version of dystrophin, or even in some of the exon skipping therapies. Next slide. So we then had to think about, you can leave, you can stay there. So we then had to think about how we're going to move this work further in order to come closer to any kind of translational impact. So we had to recreate the duplication of exon 18 to 30 in a mouse. And you see one slide here that took about 2 years to get to, because it was very complicated to use the CRISPR technology to generate this duplication mouse. But in the end, we were successful. And you can see this mouse doesn't express dystrophin, has a muscular dystrophy. Next slide. And we were then able to use this mouse, package the CRISPR scissor into an AAV9, inject it intravenously into the mouse to see whether we are able to remove the duplication in vivo and what potential impact this may have on the phenotype of the mouse. Next slide. And you can see here on the right side here the untreated duplication mouse model with no dystrophin expression. And then when we gave the intravenous injection of the AAV9 and the CRISPR guide, here you see in the heart that we get fairly reasonable expression as compared to the untreated mouse. Next slide. And here you see in the middle that we get fairly robust expression of the tibialis anterior and also forearm muscle, where we have up to 60 to 70% expression of dystrophin, which is the wild type dystrophin. Next slide. We then did a number of functional measurements on these mice. Here we measured activity of these mice. Next slide. Next slide. Okay, great, thank you. So if you look here, the blue mice are the treated mice. You can see that the total distance that these mice traveled was much closer to wild type. The vertical activity and even the average speed was much faster than the non-treated mice. Next slide. So this is just a fraction of the results we have, but I want to give you an overview how we successfully restored and ameliorated the phenotype of these duplication mice. So the question now is, what are the next steps? Next slide. And there are a number of things we need to think about. Number one, As you all know, we have currently 3 gene therapies in clinical trial, and a 4th and potentially even a 5th to start within the next 12 to 18 months. And what I think is really important is that no matter how competitive each companies are with each other, we need to share the data we learn from these gene therapies, as they're going to help inform us how to either improve certain therapies, but also how to potentially conduct certain protocols for clinical trials. So I'm always pleading for everyone to share as many data as possible and leave the competitiveness to the side a little bit. Next slide. Just for 30 seconds, everything I'm talking passionately about, and I do believe that over the next decade we have a chance for genome editing to have a huge impact in many different inherited disorders. I'm always talking about what we call somatic treatment, meaning that I'm talking about treatments of patients who are born with a genetic disease. And I'm not talking about germline treatment, which is a whole nother discussion which we can spend a whole hour on. Next slide. Next slide, please. And the other thing we need to know before we can really safely consider moving something like this into clinical trials, go back one, please, is thinking about off-target mutations. So I told you earlier that although the CRISPR genome editing technology is incredibly precise, there are certain very, very slow risks associated that the scissor that you give to the mouse or the patient later on, hopefully, is not going to cut just where you want it to cut, but potentially somewhere else. With that in mind, we have to come up with certain strategies and assays to make sure that before we think about clinical trials, that we are as convinced as possible that it's really safe to do so. Next slide. So the other aspect we need to think about as we move forward is whether there's any kind of immunogenicity or immune reaction towards the protein of the scissor. There are a number of studies that are suggesting that it's probably okay, but at the end of the day, we are giving a foreign protein to a body, and we need to make sure that whatever kind of immune response is potentially elicited, that we can treat it either ahead of time with certain immunosuppressants or during the treatment. Next slide. The other aspect we have to think about is the delivery molecule. Although everything currently is surrounded around AAV9s, and I think for the foreseeable future that will be the case, eventually we have to probably try to find a vehicle that is not as immunogenic as an AAV9, and whether these are certain bioparticles like nanoparticles or so that are significantly less immunogenic than AAV9 is probably the long-term future of the delivery. Next slide. So all of this together is a plea for you who can help us advocate for the fact that we have to change the culture of clinical trials, specifically when we are thinking about very individualized therapies like genome editing therapy. So the duplication of exon 18 to 30, which I just showed you, there's only one patient in the world who has this duplication. So how are we going to work with industry as well as with organizations like the FDA, Health Canada, or EMA in order to regulate trials for an N of 1? I think it's all possible, but we have to face these challenges before we can move to the next step and move these kind of therapies into clinical trial. Next slide. And I'm going to end here. You see that my wonderful group of people who are working with me and are really the ones who do all this wonderful work. I'm just the one who has a crazy idea, and the other members of my lab try to make work whatever crazy idea I have. And if it's too crazy, they tell me you're crazy, Ronnie, we need to try something different. So thank you everyone for your wonderful support. We couldn't do this without you. You do not know how much it means to all of us, and enjoy the rest of the evening.
Thank you, Dr. Cohen. And as always, it's a pleasure to have you with us. And I thank you for your dedication to our Duchenne community. So we will move on now to talk a little bit more about our current research members. And I think it's really important now to take a few moments to thank our current research funding advisory committee. As I mentioned a little bit earlier, our committee is comprised of Duchenne expert clinicians, researchers, and family members. And this is all chaired by Dr. Lisa Hoffman. Lisa is trained in cell biology with research disciplines in cell and molecular biology and holds a position at the Lawson Health Research Institute and the University of Western Ontario. She's had a long affiliation with Jesse's Journey, first as a research committee member, but then in 2012, but the following year she took over as chair from Dr. Allison Allen, who has played a really big role in really building the funding process and the policies that we have in place today. So on behalf of Jesse's Journey and our Duchenne community, I'd like to thank all of our committee members, past and present, for their dedication and time to this vital process in helping us decide where our generous gifts of our donors will make the biggest impact in the lives of those living with Duchenne. So thank you very much. So we're now getting to the point in our agenda where we get to unveil our new grant recipients. But before I do, I would like to make one more special announcement, and that is this year marks our largest funding year to date, granting $1.6 million. This news is only possible thanks to the generous donations that we've received in the prior years. And as Perry had mentioned earlier, if it doesn't get funded, it doesn't happen. And so he'll touch on this a little bit more and the importance of giving, especially now in the significant impact with COVID-19. But let's get back to our exciting news. And it is now with pleasure that I pass it over to our research chair, Dr. Lisa Hoffman, to say a few words and to announce our new grant awards. Lisa, I pass it over to you.
Thanks, Nicola. Can everybody hear me? Yeah, I guess so.
Yep.
Okay, so
Yep.
Good evening, everyone. I'm really honored to have been asked to speak for a few minutes here tonight. I'd like to now tell you a bit about the evolution of scientific research that has been supported to date by the Jesse's Journey Foundation. So early on, much of the grant funds awarded supported more exploratory research into the pathogenesis of DMD, or on new leading edge potential therapies aimed at diagnosis and slowing or mitigating disease progression. You'll hear about some of this work shortly. Many involved use of cells in culture or preclinical animal models such as DMD mouse models, with development of, for example, new gene editing technologies and generation of new animal models of DMD, such as the DMD canine model. This too you'll hear about shortly. We next began to receive applications for and fund therapies taking the next step in replacing dystrophin in patients, which is where we are now excitedly today with the Jesse's Journey Foundation now funding early phase clinical trials. So it's now with great pleasure that I announce our 2019-2020 research grant recipients. Our first grant recipient is Dr. Jordan Chirico, Assistant Professor of Pediatrics and Medicine at Dalhousie University, Nova Scotia. And he's also a medical director of pediatric rehabilitation at the IWK Health Center. The project is entitled, in collaboration with Dr. Carly Baxter for their project, is a survey of Canadian youth with Duchenne and Becker muscular dystrophy, exploring gender, identity, sexuality, sexual health questions and concerns. Dr. Chirico, I'll pass it over to you.
Thank you so much, Lisa, and everybody at Jesse's Journey. It's quite exciting to have our project recognized by Jesse's Journey and have the support of such a wonderful organization. So I'm thrilled to be here to talk just very briefly about our project that is put together by myself, as well as Dr. Baxter and Dr. Mokashi. Next slide. And so I want you to think about this. As individuals with DMD are living longer into adulthood, it's important that as healthcare providers, we are also providing care that focuses on quality of life. Next slide. So with that, we certainly as clinicians and clinician researchers have seen and benefited from the fantastic work both contributed to by Jesse's Journey, as well as many other researchers around the world in terms of understanding Duchenne and understanding where we can find potential therapies. And as clinicians on the ground, sometimes we start to think about what are the other quality of life issues. And this was one that struck our team as important to explore. Really, as boys are surviving longer with DMD, renewing that focus on quality of life. Sexuality itself plays an important role in adolescent development and influencing mental health, emotional health, as well as for the formation of healthy relationships, and all of that packaged together contributing to overall quality of life for individuals. And sexual health, as it's been studied in a number of areas, is an incredibly important topic for all teens. But really there is very little known about sexual health and gender identity issues across our DMD population. And our neuromuscular care team is really well positioned to support patients in these issues by providing anticipatory guidance about sexual health and promotion of independence and social development. Next slide, please. Our team has created a survey based on a number of surveys that have been done in other populations, since there isn't anything specific to DMD, to really explore the issues related to sexual health and gender, including whether individuals feel that their needs are currently being met by their healthcare teams. We are partnering with the Canadian Neuromuscular Disease Registry to send out our survey to the population across Canada. And the information will really help us understand this important topic better and to give guidance to neuromuscular clinicians, patients, and families on their concerns and experiences of the adolescent and young adult DMD population. And we really hope that this work will form the basis of understanding sexual health and gender issues so that healthcare teams can feel confident in asking youth these questions and are able to counsel and provide appropriate information and resources. Next slide, please. So our research team includes Dr. Carly Baxter. She's a second-year pediatric resident at the IWK and Dalhousie University here in Halifax. Dr. Arthi Mokashi is one of my colleagues. She is a pediatric endocrinologist at the IWK Health Center, and she's the medical director of our endocrinology trans health clinic that has been running for a number of years in Halifax. And myself, as Lisa mentioned, I'm the medical director of pediatric rehabilitation at the IWK Health Center. And we really, again, extend our sincere thanks to Jesse's Journey for their support and belief in our research project. So thank you very much, everyone, and I'll turn it back to you, Lisa.
Thank you, Dr. Shriko.
Lisa, sorry, I hate to interrupt, but Dr. Korngat actually has to go. So would it be okay if we just quickly fast forward to Dr. Lawrence Korngat next?
Yes.
Thank you. Sorry about that, guys.
Okay, so our what's going to be our fourth grade recipient is now going to be our second. So it's Dr. Lawrence Korngut of the Canadian Neuromuscular Disease Registry, of the CNDR. So Dr. Korngut is a neurologist, a clinical neurophysiologist, and director of the Calgary Neuromuscular Program and the Calgary ALS and Motor Neuron Disease Clinic in Alberta. He has been instrumental in the creation of the registry along with Dr. Craig Campbell, Dr. Jean Ma, Dr. Bigger, and others in establishing and growing the registry to what it is today. Jesse's Journey is one of the original funders of the CNDR, and we are very pleased to be able to fund the CNDR for its 12 consecutive years. Dr. Korngut, I pass it over to you.
Thank you. Hi, everybody. Can you guys see me okay? Great. So it's a real pleasure to be here. As you've heard, there's been a very long-standing partnership between Jesse's Journey and the Canadian Neuromuscular Disease Registry. In fact, Jesse's Journey has been the only sponsor that has been with us all the way along from the beginning, as you heard, about 10 years ago. And we're so grateful for that partnership. And from our perspective, it's just been an absolutely terrific partnership. And again, we're so grateful. And it's great to be able to share some of our work with you today. Some of the speakers that you've heard, each of the speakers that you've heard today have really, I think, illustrated some of the fundamental principles that went towards the development of the Canadian Neuromuscular Disease Registry. You know, there's a great complexity in these diseases that we deal with, including Duchenne Muscular Dystrophy. There's going to be a complexity of solutions to address these diseases, but it also takes the whole community to come together and work together, patients and families and universities and industry and patient organizations. And it's such a large community effort. And I really do believe that patient registries serve as a central opportunity for communities such as the Duchenne community to work together and to collect important data and information on patients, but also to engage people together and allow patients to work closely with researchers and physicians and all the other members of the community. So next slide, please. And so here you see some of the members of the CNDR. We're in 30 clinics currently with over 50 investigators. And so it's a large group of people. And so it's always an honor to speak on behalf of the group, because of course, any work that we do is as a group altogether. Next slide. And so to date, we're actually over 4,500 patients from across Canada. And on recent count, we have over 560 boys and young men with Duchenne muscular dystrophy and Becker muscular dystrophy. And as you can see, the distribution across Canada emulates nicely the urban centers, but we also have a large rural representation of folks. And I think that's important, because the CNDR to me also represents access to information, access to participation in research, and access to information about research. And so importantly, patients and families have different channels to access information, but certainly the CNDR is one where we're very proud to provide useful information about research opportunities to our community. So next slide, please. And one thing is to look at the number of patients that a given registry has, but I think it's important to recognize the productivity of the registry. And so I'm very proud of these graphics, which show you the number of studies actually worked on and completed by the CNDR in collaboration with researchers around Canada and around the world. And so you can see there's clinical trial inquiries where companies or researchers are looking for where patients with certain gene mutations may be, so they can help intelligently pick out clinical trial centers, informational mailouts, data requests to access the data. And importantly, it really is a community resource. And so we provide information to anybody. We're willing to release our data to anybody as long as they have some sort of credentials that we can trust that they're going to be using this for appropriate reasons. And in all our years, we've fortunately never denied anybody access to our data. And so it's not just for the researchers who collect the data, which again, we're very proud of. Next slide. And as you can see here across all the different diseases, we're at this point approaching 140 different projects completed using the CNDR platform. Next slide. And so what has this resulted in? So there's been a large number of publications in different diseases, including Duchenne muscular dystrophy by researchers, including many of the researchers working with the registry, but all using the registry platform. And next slide. And I think some of the studies we're most proud of are where Canadians got to contribute to a larger effort. And as you can see here, studies of 7,000 boys with the Duchenne muscular dystrophy, another one of over 5,000 boys. And this really would not be possible without us being organized, along with other countries around the world being organized and putting data together in very large numbers to glean really unique insights into these diseases. Next slide. And so I just wanted to thank Jesse's Journey and thank you all again for all of your support. We're so grateful. And of course, we couldn't do it without the community supporting us. So thank you again.
Thank you, Dr. Korngut. So our next grant recipient is Dr. Jacques Tremblay, Professor in Department of Molecular Medicine at Laval University, Quebec. Dr. Tremblay will talk to us today about his project entitled Correction by CRISPR-Based Editing of Point Mutations Responsible for Duchenne Muscular Dystrophy. Dr. Tremblay, I'll pass it over to you.
Thank you very much for the introduction, and thank you very much for Dr. Cohen to start the introduction on the new CRISPR-Cas9 technology. It's a fantastic technology that may help us to correct almost any gene mutation. Oops. Next slide. Oh. May you change your slide for me, please? I think that, as most of you know, Duchenne Muscular Dystrophy is due to mutation in a gene that codes for a very large protein called dystrophin. And this protein is normally present underneath the muscle fiber membrane and is absent in the muscle fiber of a Duchenne patient. And this leads to very frequent break of these muscle fibers and to progressive muscle weakness. Next slide. In muscle fibers, this is special. There are hundreds of nuclei inside of each muscle fiber, whereas in most cells, there is only one nuclei. Next slide. Each nucleus contains chromosomes, and these chromosomes are made of DNA, and DNA is a long double strand of nucleotide, and there are 4 different pairs of nucleotide: adenosine with thymine, thymine with adenosine, cytosine with guanine, and guanine with cytosine. So these are the different pairs. There's only 4 different pairs of nucleotide, and yet in the human genome, there is 3.2 billion pairs of nucleotide that constitute the human genome. I once calculated that it takes about 145 Larousse dictionary, which are about 4 or 5 inch thick, to complete just the listing of this human genome, 3.2 billion nucleotide. Next slide. Just the dystrophin gene itself is 2.3 million nucleotide just to code for that one protein. In fact, there are several sequences which are not coding. They're called intron, and other sequence of nucleotide are coding for the protein. They're called exons. Next slide. Well, since a few years, there's a fantastic technology called CRISPR. It's derived from bacteria that have been using this technology since millions of years to fight viruses that are infecting them. And since 2012, researchers have started to use the CRISPR-Cas9 technology to be able to edit gene. And Dr. Cohen just presented an example of the use of CRISPR to correct sequence duplication in the dystrophin gene. Next slide. Well, this CRISPR technology can be used to correct single nucleotide modification. In fact, 30% of Duchenne patients, they have a modification of only 1 nucleotide pair. And because of that one change among the millions of nucleotide that forms the dystrophin gene, the dystrophin protein is not produced, and these patients are dystrophic. Here on the left side, we have a normal gene where we have a sequence which is TGT. It codes for a cysteine. And on the right side, we have a mutation. Simply the T has been replaced by A, and this is a stop codon. The synthesis of the protein will stop at that point. There will be no complete dystrophin present in the muscle fiber, and because of this one nucleotide change, this patient will be dystrophic. Next slide. Well, as I mentioned, this CRISPR technology is started in about 2012, but at the end of 2019, there was one publication about a variant of that technology that would, in principle, be able to correct any point mutation in the human genome. Next slide. In fact, the idea is that we have on the left side a mutation where a T is replaced by A. With that base editing technology, we can change the A back into a T. You know, it's targeting among the 3.2 billion nucleotide, you're going to change one single letter. It's like doing text editing, isn't it? You're looking for a precise sequence and you change one letter because there was one mistake. Next slide. So this project is to correct point mutation, and I've used data from the Canadian Registry of Patients that was just presented, and they told me that there is 29 different point mutations that have been identified among Canadian patients, And this technology will permit, in principle, to correct these single nucleotide mutation, which are responsible, in fact, for 30% of the muscular dystrophy case. In fact, I said this was in theory, but my lab is back in business since 2 weeks, despite the current crisis. And we have been able to start some experiment. And I'm very glad to report that we have been able to correct in cell lines in culture, we have been able to correct point mutation, one in exon 35 and one in exon 9. So it's not only in theory, we know that in some human cells, we are able to correct, to modify a single nucleotide pair. Next slide. The beauty of that technology, which permits to modify a single pair of nucleotide, is that there are about 7,000 different hereditary diseases. And many of those hereditary diseases are due to a single nucleotide pair which is mutated. So if this technology, which is called prime editing, which permits to correct a single nucleotide pair, works for Duchenne muscular dystrophy, it will eventually work for all of these 7,000 hereditary diseases. This is a fantastic era. I always say to people, I am doing things I was not dreaming of doing 2 years ago. So thank you very much to the supporter of Jesse's journey. Your support is helping not only the patient that have muscular dystrophy, but it will eventually help people that have 7,000 different hereditary disease. Thank you very much.
Thank you, Dr. Tremblay. Before I introduce our last new grant recipient who will speak this evening, I just want to say that we are running late, and hopefully that all participants can stay with us for a little bit longer to hear the remaining speakers. So with that, I'd like to introduce Dr. Dongsheng Duan. Dr. Duan is the Margaret Proctor Mulligan Professor in Medical Research at the University of Missouri and a Fellow of the National Academy of Inventors. He has made many seminal contributions in the field of gene therapy, in particular in the development of the adeno-associated virus vector and gene therapy for Duchenne muscular dystrophy. His current project, funded by the foundation, is called Super AAV for DMD gene therapy in human muscle. Dr. Duan, I'll pass it over to you.
Hi. Hello.
Hi, Dr. Duan. We can see you and we can hear you.
Okay, good. All right. First, I want to thank Jesse's journey and the entire Duchenne community for the support to all the researchers over the 30 years. And without your support and your effort, it won't be possible for any of us to sit here to describe our progress. And next slide, please. I have a disclosure. I'm sitting on the advisory board for Solid Bioscience, and this company is currently doing the Duchenne muscular dystrophy, microdystrophin gene therapy trial. Next slide, please. One of the milestones in the last couple of years in the progress of Duchenne muscular dystrophy gene and cell therapy is the initiation of the systemic AAV microdystrophin gene therapy in human patients. So the goal is to, by doing a single IV injection, to get billions of the viral particles that carries a highly truncated microdystrophin to all the muscles in the body in the hope to reduce the disease. Next slide, please. And currently, 3 companies are involved in those different trials, including Pfizer, Sarepta, and Solid Biosciences. And they all use different technology in terms of the different AAV vectors, different microgenes, and the different dosages. And the next slide, please. Here I'm going to share with you one recent data that was just presented this month in American Society of Gene and Cell Therapy annual meeting by Solid Biosciences. As you can see that in these slides, on the left side is an image of the muscle that's been treated with 2 times 10 to the 14 viral particles. On the right side is a bar graph which shows 2 different dosages. One dose is 5 times 10 to the 13 viral particles. Essentially, you would barely get anything. But when you increase the dose, then you see up to more than 60% of dystrophin positive myofibers. This is not only seen in Solid Biosciences trial, but also was reported in the Pfizer trial, in the Sarepta trial. So clearly, we need a huge amount of the viral particles in order to see a therapeutic effect to get microdystrophin to the muscle. Next slide, please. So important issue is that when you have huge amount of the viral particles delivered to the bodies, anything can happen. Here I'm showing like a list of some of the events that had happened in the humans and in the large animals, in the dogs, in the monkeys, in the pigs, and in different diseases. And next slide, please. Next slide, please. Oh, sorry, can you go back to, yeah. So what I'm trying to call your attention is that in all the studies, it has been shown that when you have too much viral particles delivered to your body, there's going to be issues with immune responses. There have been patients that have liver function defect and kidney failures and blood abnormalities. And all those have been reported in Duchenne trials. And in several cases, the trial has to be placed on hold. And the other issue with huge amount of vector is that how can we manufacture so large quantity of the viral vectors? And so what is the solution? Next slide, please. So when the field decide to use AAV9 as a vector for Duchenne gene therapy, it is mainly based on what we learned from studying in mice. So this is an example showing that if you deliver AAV9 to mouse, what you can see in the heart is almost near 100% this heart gets transduced, as shown by those black-brown colors. And next slide, please. However, when you deliver the same quantity of the virus to the dogs in the same per kilogram doses, you barely get any transduction. So with this, we screen a number of different AAV capsid in the dogs. We find out, next slide, please. If you deliver the same dose of AAV8 to the dog heart, you get a good gene transfer. Next slide, please. So this suggests that the gene delivery efficiency is highly dependent on the species. Different species, the same AAV capsid may behave differently in different species. So we don't know that the AAV9 and that we are currently using in Duchenne trial, whether that's the best for human or not. Next slide, please. So our goal is to develop a model system so that we can screen many different AAV capsid to see which one works the best for the human muscle. So the idea is to take a piece of human muscle, next slide please, and put in the immune deficient mice, next slide please. And then we deliver many different kind of AAV to this human muscle, then rank them to see which one works the best. And the ultimate goal of this study is to find a AAV capsid that can efficiently deliver to the human muscle at a much lower dosage. And the implication or the significance of this study is that if we can find out such a good super AAV, it will not only reduce the toxicity because you're going to reduce the vector dose to the patients, but also it will reduce the burden of AAV manufacture and eventually the drug price when it get to patients. Next slide, please. I want to thank Jesse's Journey for the support over the many years to the research in my lab. For this particular project, we also received support from Michael's Cove, Brian's Quiz, and Pietro's Fight. And I didn't mention that I saw Pat is here. I didn't mention the project that's supported by PPMD and many other research foundations. As a matter of fact, my lab and many labs have received support from Muscular Dystrophy Association, from Parent Project Muscular Dystrophy, from Jesse's Journey. I want to thank the community for your help. Without your help, there will be no tomorrow. I'll stop here. Thank you.
Thank you, Dr. Duan. So with that, moving from one chair to another, I'd like to introduce the chair of Jesse's Journey Board of Directors, Dr. Jeffrey Preston, to announce the final award for the evening. Jeff, over to you.
Thank you, Dr. Hoffman. I have the pleasure of announcing what is a great milestone for Jesse's Journey. Through the support of our donors, we are, for the first time ever, granting $1 million to support a phase 3 clinical trial. In partnership with the Muscular Dystrophy Association in the US and Duchenne UK, Dr. Eric Hoffman from ReveraGen Biopharma is investigating vamorolone, an alternative to the current standard of care for Duchenne glucocorticosteroids. Dr. Hoffman is a human geneticist and translational researcher focused on neuromuscular disease and skeletal muscular tissue in health and disease. Currently, he is the Associate Dean for Research, School of Pharmacy and Pharmaceutical Sciences at Brigham University, SUNY. In the private sector, he is the co-founder and CEO of ReveraGen Biopharma, co-founder and vice president of the Agata Biosciences, and co-founder and president of Trins LLC, each company focusing on different aspects of orphan drug development. Dr. Hoffman joins us today from Rockville, Maryland, to talk about the great strides that he has made to bring vamorolone to Canadians. So Dr. Hoffman, I turn it over to you.
Thank you very much, Jeffrey. If we can have the first slide. So I'll give an update on the vamorolone program and then speak to the specific clinical trial, new clinical trial that Jesse's Journey is helping support. Next slide. With us, as we all know, steroids like deflazacort and prednisone keep boys stronger and longer, but they have serious side effects. And so it's all a balance of improving strength and mobility as an efficacy, but then the safety concerns of bone fragility, stunting of growth, and many others. Next slide. So what we did with vamorolone is we sort of tweaked the chemistry of the glucocorticoids to sort of turn the green here is the actual drug, and those different parts around it is what the drug binds, the receptor, and we turn it in the receptor and we start changing its activities in the body. And we ended up with vamorolone sort of customizing the drug for DMD and changing a lot of the functions of prednisone and deflazacort. So we retain the anti-inflammatory activity, but we lose a lot of the side effects. And then we add membrane stability, and we added a mineralocorticoid receptor antagonist, which is similar to a pleuronone-spironolactone, which is a cardiac drug that's used in Duchenne muscular dystrophy. And that's the opposite of prednisone. Next slide. This gets into more of the data, but is too detailed. But a key issue for the scientists on the call is we change the co-activator and co-repressing binding. So we actually increase the co-repressors, which are responsible for anti-inflammatory efficacy, by about 4-fold. And we decrease the co-activator binding, which is responsible for side effects. Next slide. So just as a summary of vamorolone versus corticosteroids, we've retained this NF-kappa B, which is the anti-inflammatory, through this differential activity of co-repressors and co-activators. We've gained membrane stabilization, which prednisone and deflazacort don't have, and that helps compensate for dystrophin deficiency. We've gained this hopefully heart-healthy activity of MR antagonism, and we've lost the transactivation and the MR agonist activities that are features of prednisone. Next slide. So I'll just go straight into clinical trials and then what Jesse's journey is supporting. We've been very active in Canada since the beginning with Jean Ma, and then more recently with Vancouver and Ottawa and Montreal, in addition to Calgary and Jean Ma. We started our first trials in 2016 with support of Parent Project and the National Institutes of Health in the US and multiple foundations and the European Commission. So 48 boys were treated for 6 months initially at different doses. Just recently, all those boys, or 41 of those 48, finished 2.5 years of treatment. And so I'll show you data on that. And most of them have asked to stay on vamorolone. The physicians and the families really want to stay on vamorolone, so have been transferred to expanded access. More recently, we started a double-blind placebo-controlled study. It was started last year. We're just about fully enrolled, and I'll talk about that later. And that will be the registration trial. Next slide. I'll just show a little data from these trials. This is published. What we see is dose-dependent improvement. So you can see the lowest dose at the bottom in red. As we increase the dose of vamorolone, we increase the ability, the speed of time to stand. So the kids get quite a bit better, significantly better over the 6-month treatment period shown here. Next slide. Well, if we look at other outcomes like 10-meter run walk, TTRW, or 6-minute walk test, or time to climb stairs, they all show similar benefits. So as you increase the dose of vamorolone, and that benefit is significantly better than kids that aren't treated with steroids, but also similar to what is seen with prednisone. So I'll go to the next slide. So then I'll show you now after 18 months of treatment. Now all those kids, including those from Calgary, transitioned to higher doses because those seem more effective. So everything I'll show now is on either 2 or 6 mg per kg per day, because that's seen. And what I'll show you is that most patients, 2/3 and their families, we let them choose which dose they'd prefer. And so 2/3 went to the highest dose, 6 mg per kg, and about 1/3 to the 2 mg per kg, so about 1/3 lower. Next slide. So here's all the boys over that 2.5 years of treatment. And you can see on the bottom the kids that started in the lowest dose, and then you can see by these different colors, they dose escalated to blue, which is the highest dose. The kids at the top started at the highest dose, and most of them maintained the highest dose. Some kids and their physicians wanted to de-escalate, so lower dose. Usually that was because a subset of kids show weight gain, and so by turning down the dose or decreasing the dose, that could possibly help mitigate that. So that's the green you see like in the top. Next slide. So if we can then compare this over 18 months to steroid naive, which is the red, and prednisone, which is the black, we see it pretty much tracks on with prednisone. So we're seeing the benefit of prednisone and deflazacort. Next slide. And we see that that is improvement. We see improvement with both deflazacort prednisone and vamorolone. And this is shown by time to stand, where if you can time to stand less than 5 seconds, there's a number of natural history studies that say that the kid's doing pretty well and probably will be stable, if not improve, over the next period of time. And so you see at baseline, there were quite a few kids that were above 5 seconds, but after 18 months of vamorolone treatment, most of them went under 5 seconds. So again, this improvement over 18 months, not a worsening like you see in Duchenne kids without treatment. Next slide. Here, this is not really a fair slide. It's just showing the single drug approved in Europe, which is Translarna, stop codon read-through, and the label, showing what the clinical trials they did. Now, these kids are all treated with steroids as well, in addition to Translarna, and Translarna just sort of blunts the decline. But if you compare that with 6-minute walk data in roughly the same scales to vamorolone, you see that improvement. The Translarna kids are a bit older, and the vamorolone kids are a bit younger. So this is not a direct comparison, not really fair, but you see, again, the improvement versus the decline in older kids. Next slide. So in terms of safety, now I'll turn to that. We have long-term patient drug exposure and subject years. We have 106 patient years now of vamorolone experience in Duchenne muscular dystrophy. We have no serious adverse event attributed to the drug to date. In the next slide, we're going to now compare to glucocorticoids. So one of the things is stunting of growth. As you know, deflazacort and prednisone stunt growth. The kids stop growing, become much shorter than their peers by the time they get into adolescence. In vamorolone, we don't see that. In fact, the kids are growing a tad stronger. It's not, or more quickly, it's not significant, but we clearly have lost that stunting of growth that you see with corticoids by that negative numbers down below and the positive number with vamorolone. Next slide. We can also look at cushingoid and weight increase. And so in a Griggs study, this was the study that was used to approve deflazacort in the US for Duchenne. You see with cushingoid, about 60% of kids showing the bloated face or the cushingoid appearance. With deflazacort, 77% with prednisone. And we only see, as patient reported, 2.6%. Weight increase also seems to be substantially less. Also, hirsutism is not reported, and mood disturbances are not reported with vamorolone at the same frequency that you see with deflazacort and prednisone. Next slide. So in summary, we see all efficacy outcomes show dose-dependent improvements over 6 months. All efficacy outcomes show improvement over 18 months as well. Efficacy of vamorolone similar to corticosteroids, although no head-to-head studies yet. That's in the blinded study. Biomarker changes argue against a placebo effect. Objective safety outcomes indicate a benign safety profile, no growth stunting, cushingoid appearance less, no serious adverse events. And now we're up to 100 patient years of high-dose drug exposure. Next slide. So now we're enrolling in this registration trial. We're enrolling in Vancouver, Ottawa, Calgary, and Montreal, and in 33 sites in 11 countries internationally. This is supported by the European Commission and the National Institutes of Health. We probably have just 1 month of enrollment left. So if anybody, it's for 4 to 7-year-old steroid naive kids. We have about 15 slots left. Coronavirus has slowed us down a bit, but we're starting to get back online. And we hope to finish this trial for FDA approval by the end of the year. Next slide. If anybody's interested in learning more about vamorolone trials, Suzanne Gagliano works for Revirgin. She's a parent of Michael, her son with Duchenne, and Michael has participated in a number of clinical trials. And there's the contact on the PIs. Next, these are the different foundations that have supported the vamorolone projects to date. Now, what Jesse's Journey is supporting is a new clinical trial. This is one that's mandated by the European Commission, EMA, so the European Medicines Agency. And Canada ascribes a bit more to the EMA than it probably does to the FDA. It has to do with how drugs are, the nationalized healthcare systems that are shared between Europe and Canada, not shared with the US. And what this is in a very broad age range of Duchenne kids. So it's going down to 2 years of age all the way through 18 years of age. And in the older kids, it's for both steroid treated to transition from prednisone or deflazacort to vamorolone, as well as steroid naive who haven't been treated with steroids in the younger age, 2 to 4, and as well as the older age. This trial, Jesse's Journey, is the first to fund this trial, and we're very grateful for their support, and that's for the Canadian sites. We expect to have sites in the United Kingdom, and Duchenne UK has also committed $1 million to fund UK sites. And in the US, we've applied to the National Institutes of Health to support the US sites. And this is under a venture philanthropy model, which is also different for Jesse's Journey. What this means is that we're maybe a year and a half away for drug approval. And so then vamorolone should then be sold. Well, if Jesse's Journey is helping support the development and taking a risk in developing vamorolone, shouldn't it also participate in future benefit? And so what a venture philanthropy model is to share risk and share benefit. So if vamorolone is then sold on the market, Jesse's Journey will get 4 to 5 times back the funding they're provided. So there's an agreement signed where for this $1 million of Canadian funding to this trial, Jesse's Journey should get 4 million or 4.5 million returned based on future drug sales. So this is a new model for Jesse's Journey. I don't know if they'll speak about it themselves, but a number of these other foundations also funded under that model, including Pat Furlong and the Parent Project and the Muscular Dystrophy Association in the US. So that's it, and I'll stop there. Thank you.
Thank you very much, Eric. It's a pleasure to meet you finally after spending so many times on calls and on Zoom chats as well. But thank you for being with us this evening. Thank you to all who have joined us this evening, and especially congratulations to all of the researchers. Speaking about the venture philanthropy model that Dr. Hoffman just spoke about, this is something that we're excited about. We're glad to be participating in the trial. That's first and foremost, that it's the first phase 3 clinical trial that we have helped to bring to Canada, and it will operate in sites in various provinces across the country, and we have more to come on that in due course. But again, thank you very much, Dr. Hoffman, and to everyone else. As Nicola mentioned before, our huge announcements of $1.6 million being funded this calendar year are only possible thanks to the generous donations of people like yourself, people who have been part of Jesse's Journey for over 25 years now. And it's all funds from fundraising, bake sales, whatever it may be, that have come to us pre-COVID-19. Our fundraising and endowment fund, as you might expect with many other organizations and companies, has been significantly impacted over the last several months by the pandemic. And we know, as we've said a few times this evening, if research isn't funded, it doesn't happen. And we will continue to work to raise funds so that we can continue to fund great projects like those you've heard here this evening. Tonight, you have seen hope. You've seen the importance of gifts from supporters, like so many of you on the line. And you have enabled the promising pipeline of research to continue and thrive. Please continue to give in whatever way that is meaningful to you so that we can continue to invest in the research for 2021 and well beyond, until that magical day when we find a cure for Duchenne muscular dystrophy, and ensuring that these treatments are available for Canadians. Finally tonight, we'd like to close with a really short video of Douglas Elton, a remarkable Duchenne ambassador whose words pretty much say it all. His quote, "Your generosity and the research it catalyzes will make it possible for more of us to dream bigger for longer." Please watch Douglas Elton.
I was diagnosed with Duchenne muscular dystrophy about 3 days before my 6th birthday. By the age of 11, I was confined to a wheelchair full-time. I'm currently 29 years old. Some of the symptoms of Duchenne include overall muscle weakness. And as you can see, I have some breathing issues, just not being able to do the the things that I used to be able to do. Whoever's helping me has to do pretty much everything. Last summer, I decided I didn't want to just live in fear, so I decided to take the big trip to Europe. Yeah, one of the biggest challenges of traveling with Duchenne was the amount of equipment I had to bring. But we had some instances of people being a bit ignorant. And they'd ask questions like, do you need all that stuff? I think it's very important for Canadian patients to have the same access to treatments for Duchenne as any other country. Certain treatments available elsewhere aren't available here because it's just as big of an issue here. My biggest fear, if I can't slow this disease, is dying of possible maybe lung failure. I think if you have dreams in your life, you shouldn't let your disability stop you.
Great message from Douglas Elton. He is 30 years old today and lives just outside of St. John's, Newfoundland. So we thank him for that and for participating as a Duchenne ambassador with Jesse's Journey. Thank you again for joining us this evening. We appreciate you joining us. We know we went a little longer than what perhaps we promised, but I think great information was shared all around. The recording and any of the questions that are going to be answered will be sent out a little bit later this week, so you'll have that. You can share it with family and friends if you wish, but most of all, that will come to your inbox at some point later this week. And most of all, stay safe in this unusual time of COVID-19. We hope that you will continue to connect with Jesse's Journey so that together we can, in partnership, defeat Duchenne. Thank you and have a good night.